Welcome to Asthma Grand Rounds. I'm Chris Fanton, and it's my great pleasure to welcome you this morning to a terrific discussion, a pro-con debate about symptom-guided inhaled steroid LABA and its role replacing potentially albuterol for intermittent asthma in adolescents and adults. This is the last Asthma Grand Rounds of this academic year, and I thought perhaps I could take just 1 second to introduce next year's program, which will, I think, be equally exciting with a whole series of fabulous Asthma Grand Rounds presentations about, well, you can see the lineup here. Perhaps I won't go through each one, but it'll be an exciting program starting in September, and we're looking forward to you joining us again. So just to remind you, our routine, we welcome your questions. Please submit them via text. Write down this number if you would. Text your questions at the end of the presentation to 617-513-6043. And then for CME credit, we'll submit your name to Harvard. If you simply send me at cfanta@partners.org, your name, your degree, and your email address will come and we'll make sure you get the CME credit for participating today. And I hope you have no technical problems, but we do have help from BWH webcast troubleshooting at partners.org. So if you find yourself with a problem, just send a quick email and they're very responsive. And so today, Dr. Dinah Foer and David Sloane will engage in a pro-con debate that I'm very eager to hear about. It's about the proposition put forward by the Global Initiative for Asthma and their GINA guidelines that symptom-guided ICS LABA should replace albuterol for intermittent asthma, at least when LABA is formoterol. And Drs. Foer and Sloane are both members of the Allergy and Clinical Immunology division here at the Brigham and Women's Hospital. They're both members of the Severe Asthma Program at the Brigham. And I'm looking forward to a terrific presentation. And I believe that Dinah Foer is first on the pro side of the argument. So I will stop sharing screen and off you go, Dinah.
Thanks, Chris. Let me go ahead and share these slides. Okay, great. Well, thank you so much for that introduction and for the opportunity to be here today with Dr. Sloane discussing this topic with all of you. And we'll jump right in. So we're all familiar with short-acting beta-2 agonists, and for decades, these inhalers have been synonymous with asthma relief, and in the process have really become the comfort object that we and our patients depend on. Patients with intermittent asthma, who are the focus of this debate today, are most often on albuterol monotherapy and rely on albuterol to rescue them. Similarly, physicians are comfortable prescribing and describing how to use albuterol, and we all know that these types of prescribing habits are hard to change. But albuterol is not the cute, cheap drug that our intermittent asthma patients have been trained to love, and my objective today is to convince you that there's a better option out there for them. This analysis compared regularly used inhaled terbutaline, shown by the solid line, versus placebo, shown by the dotted line, in patients with mild and moderate asthma, looking at trends in morning and evening peak flows over days to weeks. The short-term trends demonstrated tolerance to the bronchodilator effect, subsequent rebound hyperresponsiveness, and decreased bronchoprotection. Looking further out in time, this 8-year study of SABA overuse in 360,000 patients with asthma in a Swedish registry included over 60% of patients with intermittent asthma, defined as patients treated with albuterol monotherapy per treatment step 1 asthma guidelines. Independent of treatment step, as you can see here, SABA overuse was associated with an increased risk of asthma exacerbations. 30% of all patients in the registry had SABA overuse, and strikingly, the patients in step 1, again on SABA monotherapy at baseline, had among the highest risks of overuse, second only to the severe asthma patients in step 5. Beyond exacerbation risk, though, the study also found associations between SABA overuse and all-cause, respiratory, and asthma-related mortality, even at lower levels of SABA overuse. Those findings added to long-standing evidence on the dangers of relying on SABA for asthma symptom treatment. Studies linking SABA to asthma fatalities date back to the UK and New Zealand in the 60s and the 70s, and Canadian studies in the 80s and early 90s, underscoring that SABA use does not address underlying inflammation and leaving patients with worsening symptoms at fatal risk. Most of the studies, though, that I found on the harms of SABA and SABA overuse center on canisters as the prescription unit. However, the recently published PREPARE study points to a different potential source of SABA overuse. So in this PCORI-funded study of Black and Latinx adults with moderate to severe asthma, over 66% of participants used a nebulizer for SABA therapy, and 2/3 of participants reported using at least one nebulizer treatment per week. In a companion analysis of a subgroup of participants, patients reported using their nebulizers multiple times per week and preferring nebulizer over MDI for relief of severe symptoms. So, as in this study, if we're seeing this pattern in moderate to severe asthma, in patients who presumably have other asthma medications to help control their asthma, how much more so might we be underestimating SABA overuse in our intermittent asthma patients who are just on SABA monotherapy? Finally, if SABA use means higher exacerbation risk, then we know that that translates to more oral steroid exposure. In a recent study of oral corticosteroid OCS users, a greater percentage of high OCS use patients were being treated with SABA monotherapy at baseline compared to those who had never used OCS. So even for patients with intermittent asthma on baseline SABA monotherapy, occasional short courses of OCS put them at risk of adverse outcomes from cumulative OCS exposure, and that ranged from osteoporosis and heart disease to cataracts, diabetes, and the other diseases shown here. So to summarize so far, risks of SABA monotherapy include decreased bronchoprotection, asthma exacerbations, oral steroid exposure and its consequences, and death. These high costs of SABA monotherapy really demand a re-examination of the population at the focus of this debate, are patients with so-called intermittent asthma. So generally, intermittent asthma is understood by patients and by physicians to be the mildest form of asthma with infrequent symptoms, classically twice a week or less, treated with the minimum of medications in our armamentarium. But as these statistics here show, patients with intermittent asthma are more symptomatic than expected and are still at risk of exacerbations, including severe ones. And this may be because even though symptoms are intermittent, the triggers are unpredictable and year-round, including viral infections, allergen exposures, and air pollution. So traditionally, the terminology of intermittent asthma separated that population from those with symptoms on more than 2 days per week, based on the longstanding theory that intermittent asthma patients would not benefit from a daily ICS, while persistent asthma patients would. However, this post hoc analysis of the START study showed that in patients with mild, recently diagnosed asthma, low-dose inhaled budesonide halved the long-term risk of serious asthma-related events, reduced the decline in lung function, and improved day-to-day symptom control compared with placebo, even in patients with infrequent baseline symptoms. So this and other studies raise the important point that symptom control as well as risk reduction need to be considered when determining treatment for the so-called intermittent asthma population. And prior debates and talks have really nicely reviewed these points about ICS, and I won't return to them today. As Chris mentioned early on, the asthma guidelines reflect this evolving tension between terminology and treatment, as well as the harms of SABA monotherapy. So previously, SABA-only treatment was the accepted reliever for patients at step 1, as shown here, those presumably treated for intermittent asthma. Starting in 2019, the Global Initiative for Asthma, the GINA guidelines, moved away from SABA-only treatment for step 1, shifting towards as-needed ICS with albuterol or as-needed ICS formoterol for step 1, with still some distinctions from patients in step 2. And we'll return to the latest guidelines in a few slides. So to summarize, patients with few symptoms can still have severe exacerbations, and historic distinctions between intermittent and persistent asthma in terms of response to ICS-containing treatments may not apply. So next, I'm going to review several key trials that advance the rationale for symptom-triggered ICS-LABA in intermittent asthma. Novel Start was an AstraZeneca-sponsored 52-week open-label trial of 668 patients with mild asthma, randomized to albuterol as needed, budesonide formoterol as needed, or maintenance budesonide with albuterol as needed. Patients had doctor-diagnosed asthma on SABA monotherapy in the previous 3 months and use of the SABA on at least 2 occasions, but on average of 2 or fewer occasions per day in the past 4 weeks. The primary outcome here was exacerbation risk. Risk of asthma exacerbations, as you can see here, was lower with as-needed budesonide formoterol compared to albuterol as needed, and was superior to both comparator groups in reducing the risk of severe exacerbations. The outcomes you'll note were independent of baseline features, including blood eosinophils and FeNO. Importantly, oral steroid exposure was less than half that as in the as-needed ICS-LABA group versus either comparator, and ICS exposure in the PRN ICS-LABA group was half that of the ICS maintenance group. And we'll return to this important point in a few slides. The Symbicort given as needed in mild asthma, Sigma-1 trial, also an AstraZeneca-sponsored trial, was a 52-week double-blind trial in 3,800 patients comparing as-needed budesonide formoterol use to terbutaline as needed and budesonide maintenance plus terbutaline as needed. Here, the eligible population met step 2 treatment for mild asthma, so not controlled on SABA monotherapy or stable on leukotriene receptor antagonists or low-dose ICS-SABA. Consistent with Novel Start, the risk of severe exacerbation was 64% lower with as-needed budesonide formoterol than with as-needed SABA, and prolonged the time to first exacerbation. Overall, ICS-LABA use was associated with a cumulative dose of budesonide that was 83% lower than that with maintenance therapy. And from the intermittent asthma perspective, this study at first glance may have more limited application because of the inclusion of more severe asthma patients compared to Novel Start. But in a post-hoc analysis, investigators found that as-needed budesonide formoterol, shown here by the red bar, reduces the near-term risk of severe exacerbations after a single day of higher use, so more than 2 as-needed inhalations, even when overall use is infrequent, as it may be in the intermittent asthma population. So this study suggests that a single day of repeated use of as-needed low-dose ICS formoterol in patients with intermittent asthma may protect against development of a severe exacerbation in the near term as effectively as taking regular maintenance ICS with excellent adherence. As we've seen, both Novel Start and Sigma-1 compared ICS-LABA to SABA with slightly differing populations. Across the studies, a Cochrane meta-analysis found that ICS-LABA reduced severe exacerbations by 55%. Additionally, in a later analysis of Sigma-1 that subgrouped patients by the drugs they were taking pre-study, the annual rate of severe exacerbations was significantly lower with as-needed ICS-LABA, shown here by the red bar, treatment than with as-needed terbutaline, regardless of the pre-study treatment subgroup. Next, the practical trial was an independently funded 52-week open-label parallel group randomized control trial that included patients on SABA with or without maintenance ICS in the prior 12 weeks. Investigators compared as-needed combination budesonide formoterol with maintenance daily budesonide and as-needed terbutaline. So there was no SABA monotherapy control group, unlike novel start and sigma-1. And the population's asthma severity in this trial was sort of a middle ground between sigma-1 and novel start. Here, the relative rate of severe exacerbations was 31% lower with as-needed budesonide formoterol compared with maintenance budesonide plus as-needed terbutaline, despite participants using about 60% of the dose of budesonide. And the treatment effect was similar in patients independent of their T2-ness, their baseline FEV1, baseline SABA use, and baseline inhaled steroid use, suggesting that these findings could be appropriately generalized to those with intermittent asthma. So one common trigger that we hear a lot in clinic for intermittent symptoms is exercise. And these patients are almost invariably prescribed an on-demand SABA before exercise and then for symptom relief. And few recent studies focus on this population. And in practical and novel start studies, participants seem to have neither been encouraged nor discouraged from taking their reliever inhaler prior to exercise. In this AstraZeneca-sponsored study from 2014, inclusion criteria specified patients with exercise-induced bronchoconstriction, or EIB, who regularly exercised and who used their reliever no more than 4 times per week and had a normal FEV1 at baseline. They were randomized for 6 weeks to 3 different groups. All were on-demand treatments, terbutaline, budesonide plus formoterol, or regular budesonide with as-needed terbutaline. The patients were instructed to exercise as usual 3 to 4 times per week, and the main outcome was EIB 24 hours out after the last dosing of the study medication. So as shown here, the combination of budesonide formoterol reduced EIB in the same magnitude as regular budesonide treatment did, despite a 2.5 times lower total steroid dose, and importantly for this debate, was superior to terbutaline on demand. And importantly, measures of asthma control, such as symptoms on days of exercise, did not differ between the groups. So taken together, this suggests that budesonide formoterol on demand may be a better option for regular exercisers and may also provide better protection for occasional unplanned exertion. In some of the recent trials looking at ICS-LABA and step 2 treated asthma populations, the data suggests poorer symptom control when compared to ICS maintenance regimens. Because this debate is focusing on intermittent asthma, I want to also focus on symptom control in that specific intermittent asthma population by looking only at novel start and practical studies. Both looked at asthma symptoms by the ACQ-5 score, in which 0 means no impairment, 6 is maximal, and a minimally important clinical change is 0.5. So as you can see here, in neither of these studies was there a clinically significant difference in asthma symptom control, and most participants had well-controlled asthma, so an ACQ-5 less than 1 at the study's end. So to summarize those studies, symptom-triggered low-dose ICS formoterol for adults and adolescents in step 1 is supported by multiple rigorous studies. To date, Dinah has moved from those striped blue and orange lines that we saw earlier to advancing ICS formoterol as the as-needed preferred treatment for step 1, as well as for step 2. And this addresses many of the concerns that I presented earlier regarding the need to reconcile symptom control, risk reduction, and treatment benefit across the steps. So as-needed ICS plus SABA is the alternative for step 1, and in the guidelines, it clearly states that patients can switch across tracks. You'll notice that throughout this presentation, I've been using the GINA guidelines rather than the National Asthma Education and Prevention Program, the NAEPP ones. The NAEPP recommendations were last updated in 2020 and included changes to step 2 through step 5. However, the literature review supporting guideline development was conducted through 2018, so missing the majority of the studies we reviewed today, and potentially influencing the stark difference that you see here for step 1 therapy. And a fantastic in-depth perspective on the guideline development can be found on the Partners Asthma Center website linked to Dr. Cloutier's talk last year. Finally, as with any treatment change, we want to make sure we're on alert for any adverse effects for our patients. And this recent terrific paper from Priya Katru and Jessica Lasky-Sue in Nature Medicine observed that even regular use of low-dose ICS was associated with subclinical adrenal suppression in asthma patients, seemingly exacerbating the reduced steroid levels that are characteristic of asthma as a disease. And in balancing this potential risk for intermittent asthma patients, I think it's important to keep in mind that in the trials comparing symptom-triggered ICS LABA use to low-dose ICS use, the ICS LABA arms had significantly lower inhaled steroid exposure. Also, in the 2 trials comparing as-needed ICS LABA to SABA alone, as we just saw, systemic corticosteroid exposure due to asthma exacerbations was significantly lower in the ICS LABA arms, with the yellow faces here showing the number of patients per 1,000 who would have had less OCS exposure with ICS LABA on-demand treatment, suggesting a potential overall benefit for adrenal effects with the initiation of ICS LABA on demand. And other balancing acts will likely come up as these population level guidelines are implemented on the individual patient level. And I'll just highlight a few here, and I'm sure Dr. Sloane will bring up a few later as well. So some patients may be less responsive to the beneficial bronchodilatory and bronchoprotective effects of LABA therapy due to genetic variation. And this remains an area that needs future research in terms of how to actually translate these findings to our patients in clinic. Only budesonide formoterol was well studied in step 1 asthma, and the inhaler used in most of these studies was the Symbicort dry powder inhaler, the Turbuhaler, which is not available in the US, although the MDI has the equivalent delivered dose. And as with all medications, there are definitely insurance-related issues on the patient level to contend with. So to conclude the pro position of this debate, in my opinion, the weight of the evidence is on the side of as-needed budesonide formoterol. It avoids SABA risk for patients with intermittent asthma, and it reduces exacerbation risk, oral steroid exposure, and possibly very quickly, and does so without a decrement in clinically significant symptom control, potentially also benefiting patients with EIB, and at a substantially lower total steroid dose than maintenance low-dose ICS. Thank you.
David, you have a tall order to refute this argument. You're on, if you would.
Good morning. All right, good morning. Thanks so much for allowing me to participate in Asthma Grand Rounds. I'm delighted to be here, though I have the unenviable task of following Dr. Foer's eloquent presentation. I'm taking the con side of the argument that symptom-guided ICS LABA use should replace albuterol for intermittent asthma, and I emphasize the intermittent aspect of it because, as Dinah pointed out, this is a form which we used to refer to as, step 1, but step 1 and step 2 have sort of been conflated by the most recent GINA guidelines. So I have no disclosures, but I appreciate the opportunity to think with you about the immunopathobiology of asthma and the care of patients with asthma in a way that will limit confirmation bias. I'm the first person to admit, especially after hearing Dinah's talk, that the idea of replacing albuterol with symptom-guided ICS LABA is a pretty good heuristic. It certainly will decrease the short-term risk of a severe exacerbation in many, if not most, patients with intermittent asthma. And although we won't wrestle with the issue of smart therapy, which has been addressed in other venues, that's probably simpler and may translate into more consistent and appropriate medication use by patients. The evidence in support of this heuristic, as you saw from the previous presentation, comes from studies like the Sigma-1 trial, which convincingly demonstrates the ability of as-needed budesonide and formoterol to decrease the probability of having a severe asthma exacerbation. But note that the trial recruited patients needing GINA step 2 treatment because their asthma was not well controlled with an as-needed SABA alone, in this case, terbutaline. This is, I'm not trying to be captious here because this is still an important study, but it suggests that the study by its very design is biased against patients who do well with a SABA alone. Here's a case example of a patient I saw just this week. She's a 56-year-old woman with asthma since childhood. She didn't have any significant attacks until she was in her 20s when she started to get wheezing, dyspnea, and cough associated with exercise. She used an inhaled corticosteroid for a few years, but has not taken one in almost 25 years and has not needed systemic steroids for exacerbations. Now in her 50s, her asthma is only active with exposure to cold air or pollens. She uses albuterol as needed a few times per year with good effect. She has type 2 diabetes with fairly well-controlled blood glucose and glaucoma, and had to discontinue an inhaled nasal steroid for chronic rhinitis because of increased intraocular pressure. Does this patient need to be changed from her albuterol to an ICS LABA as needed? She's already wary of steroid side effects, and albuterol has served her well for over 2 decades. So stronger evidence that maybe she should be switched comes from the novel START trial, which Dinah reviewed. And that convincingly showed that as-needed budesonide plus formoterol decreased the rate of exacerbations compared with as-needed albuterol alone. But note the significant difference in the budesonide and formoterol treated groups in terms of the fraction of exhaled nitric oxide. That's going to be an important aspect that I'll come back to a bit later. This image just shows the Kaplan-Meier survival curve without an exacerbation, showing that budesonide formoterol clearly outperforms as-needed albuterol in this study population. Importantly, there was no minimum baseline SABA use, and 54% of patients reported using a SABA less than or equal to 2 times per week. So that sounds like some patients did indeed have what Gina previously referred to as intermittent asthma. There was no significant effect modification with respect to baseline SABA use, fraction of exhaled nitric oxide, or a composite Th2 score. But that significant decrease in the fraction of exhaled nitric oxide indicated that patients had non-negligible steroid responsive airway inflammation. So they were likely Th2 high. And maybe we should think about not measuring the baseline, but the change in some parameters to get a better sense of who should and who should not be exposed to inhaled steroids. And lastly, it's fair to ask whether metrics like the fraction of exhaled nitric oxide, even though there's an enormous literature on this, are sensitive enough to act in place of more invasive measures like induced sputum, bronchoalveolar lavage, cell counts, or bronchial biopsies to differentiate Th2 high and Th2 low patients, kind of foreshadowing where we'll go in the next few slides. Even a pretty good heuristic like this one may lack some nuance. It may not be generalizable. For example, these were step 2 appropriate patients in the majority of studies, not step 1. And the GINA guidelines acknowledge that the evidence is indirect and based on an extrapolation from step 2 to step 1 patients. And this is a reasonable heuristic to achieve an immediate short-term acceptable solution, but that's only in the setting where an optimal solution is impossible or impractical. And enrollment criteria for these studies, sometimes specified in trials, often included patients whose asthma was not well controlled on a SABA alone, and that constituted up to 45–46% of the patients in novel START. So the finding that a SABA was inferior is not really surprising. But the core of my argument is that while asthma appears to be a single disease, we've recognized for well over 2 decades now that it's really not. It's a syndrome with subsets of patients with distinct immunopathobiological processes, or so-called endotypes. And it just takes some technology here in order to tease apart the different endotypes. Those endotypes can be described in a rather robust way. This is a paper from Lotval and colleagues that describes no less than 6 endotypes. And I highlight the one at the bottom, the so-called asthma in cross-country skiers, because those patients, as Dinah referred to, have exercise-induced bronchospasm. She reviewed some data that there was a superior response among those patients to a combination ICS-LABA. But for those who respond only to cold, dry air, and they don't have a good response to inhaled glucocorticoids, it's a really an open question. Do those patients really benefit if we look at them and we try and tease away the patients who are Th2 and therefore steroid responsive? There may be a significant population of people left who don't fit that model. A more minimalist description of asthma endotypes is the simple or relatively simple Th2 positive or Th2 high, eosinophil high, and mostly neutrophil low version, versus those patients who have a Th2 low endotype. They oftentimes have low or undetectable eosinophils. They may or may not have elevated neutrophils in sputum. Sometimes when they're both low eosinophils and neutrophils, that's called pauci-immune. Sometimes when they're both high, that's mixed granulocytic. Different studies, of course, have used different cutoffs for abnormally increased eosinophils. Some examples here. But back in the late 1990s and early 2000s, evidence appeared suggesting that there may be a subpopulation of patients with more neutrophil dominant than eosinophil dominant or Th2 low asthma. And this study by Ian Pavard and Chris Breitling focused on those with less than 3% eosinophils. And you can see that compared to the group that had more eosinophils, there were significantly decreased responses in terms of the FEV1, symptoms, peak expiratory flow amplitude percentage, and the doubling doses on the PC20 when the patients were exposed to budesonide. Shortly around that same time or shortly thereafter, Sally Wenzel's now iconic study of bronchial biopsies in patients with asthma showed that some lack eosinophilic infiltration. For example, this patient on the top row has eosinophils and neutrophils, but the patient on the bottom row has no detectable eosinophils on bronchial biopsy, but certainly has neutrophils, and that's reflected in this table. We normally think of eosinophil low, neutrophil high asthma as severe and steroid resistant asthma, and reasonably so, as this description was in patients with severe refractory corticosteroid dependent asthma. But not long after, evidence appeared suggesting that some patients with mild asthma, here patients who are only on a beta agonist, like albuterol or terbutaline, had neutrophil dominant disease, and that those patients with neutrophil dominant asthma who needed step-up therapy did less well with the addition of steroids. Here it was budesonide 400 micrograms daily than those who had a more eosinophil dominant form of asthma. You can see there was a slight increase here in the PC20. There was actually a loss of FEV1, and there was some improvement in symptoms, but not as great with the eosinophils. And indeed, this study by Simpson and colleagues showed that non-eosinophilic corticosteroid unresponsive asthma spans the spectrum of asthma severity, including mild asthma. They used a low cutoff of 1.01% eosinophils, and they showed that in the short term of 4 weeks and in the longer term of 5 years, these inflammatory patterns were stable. So here's the neutrophil dominant one, and here's the eosinophil dominant one. These images just show a neutrophilic asthma patient, eosinophilic asthma patient, mixed granulocytic and pauci-immune. And looking at the expression of genes driven by IL-13, Woodruff et al. Looked at the expression of genes like periostin, CLCA1, SERPIN-B2, and they were able to cluster patients into a Th2 high and Th2 low subgroups. Importantly, they showed again that the patients in the Th2 low group had a significantly lower beneficial response to the introduction of inhaled corticosteroid here, fluticasone at 4 weeks and fluticasone at 8 weeks. Indeed, it's even possible that the Th2 low group saw a decrement in their FEV1 when inhaled corticosteroids were started. And this may be consistent with the observation that corticosteroids certainly induce apoptosis in eosinophils, but may actually prevent or inhibit apoptosis in neutrophils or a subset of neutrophils. So this study by McGrath et al. Looked at patients in the Asthma Clinical Research Network database. They used induced sputum eosinophil counts to define non-eosinophilic asthma using a 2% cutoff. And they found that there were 3 groups. There was one group that was persistently eosinophilic. There was a second that was intermittently eosinophilic, and a third that was persistently non-eosinophilic. And it's important to note that this was true both for patients not treated with inhaled corticosteroids and those treated with inhaled corticosteroids. And that group went on to ask whether peripheral blood eosinophil counts or percentages and fraction of exhaled nitric oxide are good tests. They constructed receiver operator curves, and they found that using a threshold of 220 cells per microliter of eosinophils was 72% sensitive and 69% specific. The fraction of exhaled nitric oxide, their cutoff was 20 parts per billion, and that was 64% sensitive and 73% specific. And so those are good tests, but not great tests. Importantly, if we go back to the novel START trial, which seems to be very strong evidence for switching patients away from a SABA to an ICS LABA, you see that in the pre-penultimate and the ultimate lines here, rows here, that the median fraction of exhaled nitric oxide was 37 to 40, so well over that 20. And the blood eosinophil count was in the 300 range, so over the 220. And going back to McGrath et al., they showed again that the introduction of steroids was helpful in the dark bold line here and the dashed line here for patients with eosinophil dominant asthma, but there was really no improvement for the patients with Th2 negative asthma. Finally, you've seen these data before if you've been to or viewed previous asthma grand rounds, and this is from the Sienna trial. They specifically looked at patients with mild asthma with low sputum eosinophil levels, and patients had mild persistent asthma, so this might be an all the more so situation than patients with just intermittent asthma, although again, Gina no longer distinguishes between intermittent and mild persistent asthma. 73% of patients had low eosinophil levels, and that kind of fits with what we saw above in the McGrath study, where 64 to 83% of patients with mild asthma had non-Th2 or Th2 low asthma. The response was determined according to a hierarchical composite outcome that incorporated treatment failures, so exacerbations, asthma control days, and the FEV1. And among patients with a differential response, which a significant majority had a differential response, but a significant plurality did not. But importantly, there was no significant difference in the response to mometasone or tiotropium as compared with placebo. Finally, I'll just go back to the study that Dinah rightly drew our attention to from our friends at the Channing, looking at metabolomic profiling, looking at extensive adrenal suppression due to inhaled corticosteroids for asthma. They found substantial reductions in 17 endogenous steroid metabolites. There was a dose-effect relationship with steroids and ICS treatment, but even at low levels, there was a significant finding and a significant association between adrenal insufficiency like fatigue and even anemia in the patients who received ICS. And you can see that here, that in a number, in these two populations of the 4 that were studied, there were significant decrements in a number of these steroid metabolites. If you look at the diurnal pattern, you can see the patients with asthma on ICS at the bottom here in the dark red, at their peak, never even reach the minimum for other groups of patients, certainly not the normal patients or patients with asthma, but no ICS. So there are good motivations for and unintended consequences of a one-size-fits-all heuristic, like putting everyone, regardless of their asthma phenotype or endotype, on an ICS LABA. The good things include equity, ease, economy, elegance, and maybe even education. So those are my 5 E's. But there are some not so good effects of that, like uniformity of approach, ignoring patient differences in efficacy and side effects. And we always, it's not a reason necessarily to avoid what's best for patients, but we should just be aware that if we oversimplify decision-making processing we mechanize it too much, then we can run the risk of robotifying practitioners. So in summary, extrapolating from step 2 to step 1, patients might not be justified. Trials of step 2 patients may be biased toward a failure of an as-needed SABA. The logic here is that asthma is a syndrome with distinct endotypes. One of those endotypes is TH2 low and possibly neutrophil predominant. That affects a significant subset of patients with intermittent asthma, and it's stable over time. Those patients with TH2 low asthma are not responsive to inhaled corticosteroids, and even low-dose inhaled corticosteroids may have negative effects on patients. Therefore, my conclusion is that treating all patients monolithically with intermittent asthma with an ICS LABA isn't called for and might harm some patients who have the TH2 low endotype. Instead, we should just do a better job identifying which endotype operates in a given patient and treat that patient accordingly. So if you'll, for the last 45 seconds, if you'll indulge me in an overextended analogy, we're sort of in a position parallel to that of the development of physical theories of falling bodies. Aristotle posited that the velocity of a falling body was proportional to its weight divided by the density of the medium it was falling through. That seemed to work well for people for a couple thousand years until Newton came along and refined our understanding, and note that he had to invent calculus or co-invent calculus and use vectors to describe forces, gravitational forces, accelerating masses. And that worked well for a few hundred years until data about light and small particles at very high velocities forced Einstein to rethink things and note that he had to use tensor calculus in order to really change our model from forces accelerating in a gravitational field to really bending space and time. So I'll just end here by quoting this adapted verse from Proverbs, Hanoch lana'ar al pi darko, train the youth according to his way. Maybe we should treat the patient according to their endotype. Thanks so much.
Thank you, David. And I'm excited to bring Einstein into this discussion. I think that's terrific. And we have a time for questions, which we'll look for from the audience. And maybe, I don't know, would you enjoy a chance for rebuttal? Is that, does this presentation, Dinah, give you some thoughts about how you would react, or shall we just go ahead with the questions? We can go back and forth with a couple of minutes of rebuttal or just proceed. What do you think? Do you have some thoughts, Dinah, about what David was saying?
Sure. I mean, I'm happy to do whatever works best for the webinar, Chris. But I mean, David obviously made many brilliant points, and I love the Einstein at the end as well. Can't argue with Einstein. I think, you know, I would say that one of the most thought-provoking parts of David's presentation, I thought, was that case, you know, the patient case thinking, you know, these are population level guidelines that are taking population level risk into account, and bringing it back to the patient always does make us reflect, you know, what would we do in that case? And, you know, at first thought, I would think, oh yeah, she's doing great on albuterol, just like keep her on that, right? But then I think, you know, let's think ahead for this woman, right? As physicians, we always want to think, you know, maybe where the patient themselves can go. And let's say in 5 years, she goes to vacation in Maine, and she's staying in a cabin with her family, and there's a lot of allergens there, and she is triggered unexpectedly. And she's relying on that albuterol, which overuse leads to harm, has to go to the hospital, gets a big whopping dose of oral steroids. Her glucose goes through the roof, her cataracts get worse. And then we look back on this opportunity in clinic 5 years earlier to say, well, were we being a little complacent with her albuterol monotherapy? Were we not thinking ahead? Should we just put her on that, as needed ICS formoterol? Maybe in that cabin, she would have had earlier relief, quicker relief, and as the data shows, avoid that imminent exacerbation. So I think that that's just part of the thinking, that we need to go through as these new guidelines come up, thinking, what will work for each of our patients in their respective situations.
And David, what's your thought about putting your patient who's doing well for 25 years on albuterol and switching to the ICS LABA?
Right. Well, Dinah makes a fantastic point, and I've actually discussed it with that patient. I just want to mention two quick things before I get to my response to that, though. I really appreciated Dinah looking at and bringing the data about the exercise-induced bronchospasm and the fact that there were indeed patients who did better, and the overall findings were that the ICS LABA was better than a short-acting beta agonist in that population. And it just suggests that, again, maybe we need to do a better job kind of looking at overlap among endotypes and really parsing out who is and who is not appropriate for what therapy. When it comes to that patient who is already wary of steroids, and I've discussed this with her multiple times, I really think in a kind of 2x2 grid about the clinical encounter. There's the patient who's worried and the patient who's not worried. There's the practitioner who's worried and the practitioner who's not worried. And it's a balance of forces. When both the patient and the practitioner are worried, I tend to do the most conservative thing and leave the communication lines open. Call me if you're in that cabin and it's not going well, and for sure, we'll adapt as needed. If the patient and the practitioner are not worried, they're still on the same page, then I think it's reasonable to remain open to changes in patient concerns. But I think there's an overall agreement there that maybe you don't want to push the patient into something that she resists. It's when there's a difference, when the patient is worried and the practitioner is not, or when the practitioner is worried and the patient is not, that I have to kind of balance those forces. And so in her case, I've certainly kind of said, this is available to you. These are the guidelines. It's available to you. Let me know the second you want it. I even sent in a prescription. You just pick it up. If you're going to go on that trip and be in a really isolated area in a cabin and there's a gigantic cloud of birch pollen heading your way that they can see on the weather radar, and you start to feel it, then by all means, just for a few, for maybe a couple puffs, maybe just for a day or two, I think that might be a reasonable backstop to make sure you don't get a severe exacerbation. So I have to say that in my own practice, I really gravitated more towards Dinah's perspective than the one I was defending today. I'm guilty of being the guy who is always looking for a simpler, universal solution. So I see great value in the pro side that Dinah presented.
I'm just going to remind people who are listening who want to submit a question, just text it if you would. Here's the number, 617-513-6043 for submitting a question. So tell me, Dinah and David, do you have a sense, we're talking about patients with intermittent asthma. What percentage of adolescents and adults in our, 25 million asthmatics, do you think fit into this group? Do you have a sense, are we talking about 40% of all asthmatics having intermittent, or 20%, or do you have a suspicion or some sense of what piece of the pie we're asking to considered changing therapy for?
Right. That's a fantastic question. I do not have a numeric answer, but I'm really interested in this issue because there is a question again of sensitivity. And I don't mean this to be like a kind of ad hominem argument, but as Dinah rightly pointed out, those studies like the Sigma and the Novel, they were sponsored trials. And so we oftentimes in real life encounter people who might just at the bus stop report to us asthma symptoms, but they've never seen anyone, or they're distrustful, or they're in a subpopulation that doesn't access healthcare as readily. And so I don't have a numeric answer. I'd be interested in your opinion on this, Dinah. But I do think that there's probably a large component of the iceberg that's under the surface that we don't see. And so, these trials are good, they're important, but we shouldn't lose sight of the fact that they're sponsored by companies. And I know there have been many meta-analyses and reviews showing that sponsored trials tend to find positive results for the products of the sponsors.
Yeah, I think, Chris, there's probably an epidemiologic study out there with the exact percent. And so I don't want to misrepresent that offhand. And yes, I agree with David. I think we always need to think about trial sponsorship, who is driving the interest, who drove Albuterol and made it a cheap drug for so long, who sort of drove complacency with using ICS, with maybe, turning a blind eye to some of the side effects that we're just learning now. But I think that that's always important to remember. I will say that one of the trials that we did review today was independently sponsored. And so that is always important to see as well. And then just going back to an earlier point, that I think both David and I had mentioned, is this question of exercise-induced bronchoconstriction and athletes. And, I was only able to find this one study that was fairly recent showing a potential benefit of switching to symptom-triggered ICS formoterol for people that exercise 3 to 4 weeks, but those weren't elite athletes. And I think, the elite athletes that we see in clinic who go for very long runs, multiple times a week, and who may not want a lot of steroid exposure, maybe because of requirements set by their institution or their organization or otherwise. I think that is still, a population, one of those examples of patients, to David's side of the debate, that we really would want to think, what is the right medication for them? What is the right approach for them? And I think that that's still an open question to be studied.
I'll just add in also that I agree with that, but I would also say that as much as there has been really great science done, there's clearly more to be done. And if there were, tighter and cleaner descriptions and ways to distinguish among, for example, endotypes, and somebody showed me really solid data saying, yes, even among patients with exercise-induced bronchoconstriction, we removed those patients who were Th2 in terms of their endotype, and we still found a significant benefit to the ICS LABA over the short-acting beta agonist. That would really interest and convince me towards Dinah's side. But I think she's right in saying that there's still a little paucity of data on these more precise nitty-gritty questions, but it's sometimes in those extreme groups that we kind of push forward the borders of our understanding of asthma as a syndrome.
One of the questions that came in had to do with the recent report about use of albuterol with combined budesonide, so short-acting beta agonist with an inhaled steroid, an ICS-SABA combination. And if that were available to you, would you think it would have the same impact as the ICS formoterol, the data that we've been looking at?
That's a really fantastic question. And I'll just say briefly that study, which just came out in yesterday's New England Journal of Medicine, was among patients with moderate to severe asthma. It's hard to say without really kind of doing a head-to-head trial there. But it's really asking a profound question, which is when it comes to things like prevention of exacerbations and need for systemic steroids, how do you parse out the benefit conferred by an ICS LABA? Is it 50-50? Is it 80-20? Is it 90-10? My suspicion is that the majority of the benefits seen with an ICS LABA would be seen with an ICS SABA. And the reason I think that is because my guess, and this is just hazarding a guess, I conjecture that probably the greatest benefits are seen from the steroid part, and that what the SABA would do would last 2 to 4 hours. And during that time, there would be a sufficient time for the steroid to start having its anti-inflammatory effects. And then you would see the steroid kind of pick up after a few hours to confer benefit. If you have a longer acting a LABA, a longer acting beta agonist, fine, maybe all the better. But I don't know that I suspect that you'd keep most of the benefit with the ICS SABA that you see with the ICS LABA.
We talked about side effects, mainly focusing on systemic side effects and the concern about systemic absorption is reflected potentially in adrenal suppression. What about topical side effects? I don't remember seeing much reported in the studies that you quoted, Dinah, but I'm aware of the high frequency of dysphonia among my patients who regularly use an inhaled corticosteroid. I think a very common side effect is hoarseness, and I'm wondering if intermittent use might also have a local side effect.
That's a great point, Chris. In the studies and in the meta-analyses, they do comment that no new safety signals were detected. There were no new sort of other adverse events that came to light. And in the GINA guidelines, actually something that surprised me said that you don't even need to rinse your mouth out after the ICS LABA, which is sort of like when you tell someone to start using an ICS, you're like immediately thinking about telling them that, right, to avoid thrush. So I think that that was surprising and reassuring. So I don't know if that would also sort of apply that same concept to less use, less risk, similarly to dysphonia or not. My sense is that the dysphonia comes from frequent use and not just from, intermittent use. And in the trials, people were only using the drug maybe, an average of 3 to 4 times per week at most. And I think in the real world setting with many of our patients with, even more intermittent asthma, they may be using it much more infrequently. So, just top of mind, that wouldn't seem like a huge concern to me, but definitely one of those things that as we translate the guidelines to clinic would be something to look out for.
Yeah, I agree. I will just say that I think, again, that the concern about some topical side effects like thrush or like dysphonia, that's a heterogeneous population as well. There are a lot of patients who I think, as Dinah said, do just fine, especially with the infrequent use, and so they don't get that. I've had a couple patients just, by allegorical reporting, that on their first attempt at using a dry powder inhaler, it's the dry powder that really bothers them. And it's not even necessarily the steroidness of it, it's the dry powder aspect of it. But those patients oftentimes have laryngeal reflux or gastroesophageal reflux. They're prone to vocal cord spasm. And then, of course, there are a few patients we see in the immunodeficiency clinic who have a true immunodeficiency. They're very prone to getting thrush. And so in those patients, despite Dinah's right about the GINA guidelines, I still tell them to rinse their mouth out because even a couple puffs will promote them getting thrush. So I think probably the concern about it, to remain aware of it is good, but again, to be as precise as possible with the details of the given patient.
Well, I want to thank you both, Dinah Foer and David Sloane. A terrific discussion with both clinical implications of how we treat our patients and a look at the asthma pathobiology and science as well. So I very much enjoyed it, and I thank you. And we look forward to audience joining us again in September. Take care. Enjoy the weekend.
Thank you.